So Rita, you're here in Australia really advocating for, exposing the dangers behind gender ideology and the effect that that's having on child medicine. In Australia, we're right in the middle of it. We need it to be more exposed because our medical industry, our legal industry seem to have really capitulated to this ideology. But first of all, what's your experience in terms of your professionalism? And then I'd like to just ask you questions about, your role in terms of seeing the dangers of this and how you turned in terms of acknowledging the harms of gender medicine.
So I'm primarily adolescent psychiatrist by profession. I'm also professor of adolescent psychiatry in Tampere University, but I practice adolescent psychiatry and forensic psychiatry. And in Finland, about 2010, the issue was raised whether minors under 18 should have an access to gender identity assessments that may ultimately lead into gender reassigned medical interventions to modify the secondary sex characteristics. Before that, only legal adults could access these services. And our university in Finland, these services are centralized to 2 of the 5 university hospitals. I was then the director of the Department of Adolescent Psychiatry in Tampere University Hospital, where the adult service was operating. And it was then given me, the task was given to me that we have to establish a service for adolescents, children and adolescents.
Right, and this was happening around Europe at the time. Other European countries we had the Dutch protocol, and then they were doing this sort of medicine, what we call perhaps the gender affirmation approach, which is not questioning a child when they come with gender dysphoria, and then you put them on this medical pathway. How did you respond to that when that came to Finland? Did you feel like there was pressure to go along with it? Did you have questions?
Oh yes, certainly. Because in adolescent psychiatry, we basically operate from the assumption that identity consolidation, identity achievement is the outcome of adolescent development. And therefore, it was basically challenging to think that the one facet of identity would be so established and consolidated in early years of adolescent development that it would be justify intervening in the healthy developing body. However, the Dutch model of care was then just emerging. You didn't talk about gender affirming care at that time. It's a later terminology. But the Dutch model was coming out. There were some clinics in Europe, London, Amsterdam, Stockholm, that had been working with children and adolescents with gender dysphoria. And they were much inclined to start using the newly emerging Dutch protocol. Everybody was greatly interested in the Dutch protocol. We had big seminars in Europe learning about the Dutch protocol. So that appeared to be, the thing of today, that time. We also learned about it. We familiarized ourselves with the activities of those older clinics and felt indeed a certain pressure that the same services have to be available in Finland. So we prepared to work in the same lines as were described in the Dutch protocol.
So you treated a number of children according to this protocol?
Well, then what happened next? We were expecting to see a certain kind of young people, those kids who would have had gender dysphoria from early years, like already pre-pubertally from childhood, like identifying cross-gender already over years, and this identification would have intensified and gender dysphoria intensified during puberty. We also expected that they would be psychologically well, maybe only having secondary mental health issues because of the development of the secondary sex characteristics. And this would be the ideal case for the Dutch model. But actually, the patients who started to come in were nothing like described in the Dutch protocol, so we saw a totally different patient mix.
And what do you mean by that? What type of patients surprised you when they were coming to you for care?
Well, firstly, they were mainly biologically female, while the literature at that time was talking mainly about biological males identifying females. In Finland we always saw a great majority, about 80%, even 85% biological females. Then they presented in our clinic on average at age 16, so they were most of them were well beyond early phases of puberty. And what is most important, they mainly had a long history of psychiatric issues, severe psychiatric morbidity. They had a long history of needing specialist-level psychiatric treatment, and their first concerns about their gender and first feelings of gender dysphoria had ever developed in the context of severe psychiatric issues, and that we found very confusing.
And just talk about that in terms of your ethical dilemma, as you've been taught this, you've attended lectures, in some way you're convinced by the things you're hearing that this is the best approach. But obviously as a professional you had questions. What was your journey of coming to realise that this actually isn't in the best interests of your patients?
Well, we liaised a lot with the older clinics in Europe and had lots of consultations and get some courage that definitely the gender identity issue is so fundamental and genuine that will help. And then some young people then proceeded to the medical treatment pathway. But after a while we started to see that they didn't get better. If they had severe psychiatric issues, developmental difficulties, they were lagging behind in the adolescent development, the different facets of adolescent development like peer relationship, romantic and erotic relationships with parents, academically and everyday functioning. They were not getting any better.
Is this because you were continuing to follow up care with these individuals, or was this research done that was after the medical interventions?
At that time, our system was such that when somebody was put on the medical pathway, they had to be under our follow-up for at least a year, and then after a year, or when they were 18, so if they were, let's say they were 15, that would be 3 years before they could apply for changing the identity documents. And they had to stay, we had to follow up them until the changing of the identity documents, and we needed to obtain a second opinion from the other clinic. Therefore, we had a good contact with all these young people until they were at least 18 and wanted to apply for the identity documents. So we started to see clinically that none of the difficulties they were presenting with were getting any better. And then we of course build up research and made it official. So we quite soon started to publish papers on our findings, and we got convinced that the expectations, how much the life will get better, and to what extent different problems these young people present with would get resolved with medical gender reassignment. Those expectations were definitely not met, and that's why we actually applied for a national guideline from a body that's responsible for giving a very weighty national guidelines for what is included in the publicly funded health services.
And was your report opposed by activists? Was there outcry over the things that you said in your report?
Well, of course, not everybody liked it, and not everybody liked the national guideline either, which became rather conservative compared to the developments that were going on in Europe. Quite many countries were eagerly going according to the Dutch model, and I must say that the Dutch model was also starting to be used very liberally. Unlike their original guidelines stipulated, they had quite strict threshold for using the medical pathway, but the Western world got so enthusiastic about the model and started to apply the medical pathway to all younger patients, and regardless of severe psychiatric issues, and more liberally in any possible way.
And now you're motivated enough by this to travel across the world to speak to Australians about the harms of gender medicine and the science behind this. You've lived through, you've seen yourself, in front of your own eyes, the harm that this has had to young adults. So I'll just ask, why have you now given so much of your focus and attention to exposing this issue all around the world?
Well, first I thought when I saw that the treatment did not function as expected, then I started to write my first scientific publications on it, because I thought it's my duty as a medical doctor. If I observe an irregularity, an unexpected harm, for example, it is my duty to inform the scientific community immediately that this is taking place. So I of course expected that that people will get alarmed and rethink. Mm-hmm. But not everybody liked that information, even in the professional circles. However, some have been most interested. And then when the Finnish guideline came out, I was nominated the spokesperson for the guideline concerning the young people. So I was the one who responded to interest. And we were so astonished in Finland that our guideline awoke so much interest internationally. So that's why I have become the person who speaks about it and have been contacted by different parties, medical communities and the media around the world.
Yeah, and just to end as a final question, what would you say to medical professionals who are feeling conflicted? They're having patients present to them with gender dysphoria. They're confused about their gender. They're being told through their guidelines that they are to affirm the child within their chosen gender and to put them on this medical pathway if that's what the child desires. So what would you say to medical professionals that do feel conflicted whilst they're speaking with their patients?
I really think that so far, by now, it has not been demonstrated that this medical pathway would fulfill those expectations that were given to it. So you can modify the secondary sex characteristics of a human being, that's known. But you cannot resolve any other problems with this, and therefore we have to be cautious. It really has to be under very careful case-by-case assessments, and I should say that only a few of those children and adolescents who nowadays think that the solution to their problems is gender affirming care actually should proceed. It is the risk of harm is so great that there has to be very, very individual assessment and consideration. I think that, for example, in our clinic, I can tell that most of the young people who get a referral to gender identity assessments, we can't think that they should proceed to medical interventions right now. They can rethink about it maybe when they are a bit older. But if they currently have severe psychiatric issues, they should be the priority, the treatment of the psychiatric issues, for example, and the developmental difficulties.
And I think your message is probably a great relief to medical professionals that do feel ethically conflicted with the things that they are told to do, and to know that there is good evidence out there. We saw in the UK CAS review, but also your papers coming out of Finland and really through much of the scientific community. So thank you for speaking out about it. Obviously, as the Christian lobby, we see this as a deep spiritual issue as well. And but we understand there's science that backs up this reality that there is male, there is female, and for a child to be affirmed and valued in who they are is really the most important thing, and to care for them holistically. So thanks very much for coming to Australia, and we appreciate you.
Thank you.